Presenting a case of bilateral isolated rectus palsy. Abducens nerve palsy is seen as a false localizing sign in patients with raised ICP of any reason, but isolated abducens nerve palsies associated with intracranial aneurysms have rarely been reported. Proposed mechanisms for bilateral abducens nerve palsy associated with subarachnoid hemorrhage include direct compression of the bilateral abducens nerves, vasospasm of the pontine branches of basilar artery, and hydrocephalus. Spontaneous recovery rate is in unilateral palsy is 12 to 73% in 6 months with a median time of 90 days. The predictors for non-recovery may include complete palsy and bilateral palsy. Surgery is currently indicated in those who have not recovered within 6 months to 1 year after injury. The success rate of the surgeries range from 30 to 80%. Coming to the case report, a 21-year-old male presented with double vision since 8 months associated with limitation of movements of both eyes. Patient also complains of inward deviation of both eyes. Patient gives history of road traffic accident 8 months back and sustained head injury and was diagnosed as bilateral temporal lobe contusion with subarachnoid hemorrhage. Patient was in coma for a week and underwent decompressive craniotomy for the same, following which patient gives ocular complaints. On examination, patient had face tilt to the left side and esotropia more than 45 degrees on the left side. Anti-segment of both eyes were normal and squint examination revealed greater than 45 degrees of esotropia with nystagmus on attempted abduction. So this was the position of eyes on all the cardinal gazes. Pupil was reactive to light in right eye while there was relative afferent pupillary defect in left eye. Dilated indirect ophthalmoscopy revealed normal fundus in right eye and pale disc in left eye. So the extraocular movements, the right eye dextro elevation, dextro depression and this were restricted similarly in left eye. The management options, that occlusion of one eye to elevate the diplopia, which was given as an interim measure for this patient. Prism lenses to elevate diplopia and botulinum toxin, patient was not accepting this. So we went, next option is surgery, which is medial rectus resection. So initially we'll do force generation test. So if it is positive, it shows there is paresis, that there is at least some power in the lateral rectus muscle, so we can go ahead with lateral rectus resection. Or if it is negative, that shows that there is palsy of the lateral rectus muscle, so we will go ahead with medial rectus resection. So this patient underwent both eye medial rectus resection under local anesthesia. So this is the post-operative images in all cardinal cases following the both eye medial rectus resection. So isolated loss of lateral gaze with no other cranial nerve signs, no pyramidal tract signs, and no signs of muscular entrapment is thought to result from an injury to the peripheral nerve along its course from the brain stem to the lateral rectus. Bilateral palsy is extremely rare and is thought to indicate severe trauma to the head and neck, and the appropriate high index of suspicion for associated injuries must be maintained. Spontaneous recovery may occur in 6 to 12 months, but surgery may be indicated if patient doesn't recover in this time period. Since spontaneous recovery is possible in 6 to 12 months, referral to ophthalmology of such patients is recommended with close observation for 6 to 12 months. Non-surgical options in the interim period include occlusion therapy, prisms, and botulinum injections. Surgery can be planned for such patients if spontaneous recovery doesn't occur in this time period. Some references.